Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon, and I'm one of the chairs and organisers of Grand Rounds. And nice to be back. I missed last week. I'm afraid I was in London at I was actually attending a talk by Professor Sir Jonathan Van Tam of Deputy CMO fame, talking about the COVID pandemic. So I hope you'll excuse me that I missed last week's Grand Rounds. I was otherwise usefully engaged. But the talk was recorded and I've uploaded it to YouTube. We're just going through the copyright check and it should be available to you later on this afternoon. So this week back in the office, and I'm delighted that Rasad has agreed to talk today at Grand Rounds. Now Rasad is an ENT trainee, but he's taking time out of program to do research, working with Professor Brian Litworth in the Scottish Respiratory Research Unit. We were just talking beforehand that he's in a long line of interesting folk who've done that job, myself included, although it's shocking to realise that in June it'll be 20 years since I started my MD with Brian, which makes me feel awfully old. Now, one of the joys of Grand Rounds for me is that we hear things about all of medicine, nursing, dentistry, and all medicine professions allied to medicine. And when something is outside of the chest cavity, I'm always pleased to hear about it. Now, this is, I suppose, strictly inside the chest cavity, but it's nothing to do with the lungs. So I'm delighted that, Rasad, you've come to talk about something which is very interesting, something that for any of us have ever done an ED A&E job we all know about, which is food stuck in the esophagus and desperate attempts to free it by drinking cans of Coke and various other things. And everyone who's ever watched any movie ever knows about the Heimlich maneuver. So Rasad, I'm interested to hear your talk, where you're going to talk about food stuck in the esophagus, what's the crack, with a tantalizing background of food, which reminds me I need to have my lunch. So any questions, please put them in the chat along the side. We'll get to you at the end. Rasad, thank you so much. On you go.
Thank you. Thank you for the invitation as well and this opportunity to give this talk. So, yes, I hope some of you at least have had some lunch already today. So, and some of you who haven't had, maybe this will make you to choose a different type of food after this talk. But hope this will not affect too much of your daily life starting from today. So, this talk is going to be on the acute admissions of patients that were admitted with food bolus obstruction to ENT department in a 4-year period. So some time ago, more than 5 years or 6 years ago, starting from 2016 to 2019. And I did this retrospective audit with one of my consultants. Some of you might know Mr. Majumdar. And I've presented this talk in some meetings already prior to today. So I've already given this talk to my colleagues in Scotland at the ENT Scotland meeting, to gastroenterology colleagues here in Ninewells Hospital, as well as pathology department colleagues in early in 2021. And I've given some talks as well at the Scottish Registry of Eosinophilic Oesophagitis, and this condition will be relevant in this talk, as well as I presented this twice in Latvia. And you might ask why in Latvia. That's where I'm from, and I've gone there for some meetings. I'm going to present this as well in coming months at a British ENT meeting in Birmingham in February 2023. So why did I have this idea of having a look at these type of patients admitted to ENT department? I think I was a core trainee as well in a Ninewells Hospital at some stage. So I think it was because I came across this one patient on several occasions. So it was in 2016, a patient was admitted with a chicken food bolus, and we did a rigid oesophagoscopy under general anesthetic, and we removed the food bolus, and then a follow-up investigation with requested barium swallow, which was normal. Then the patient was admitted after a year and a half, again with a chicken food bolus, which spontaneously passed. We organized OGD, but for unknown reason, it did not take place. Maybe patient did not attend or some administrative error took place. And then patient came again after 6 months with a beef food bolus. OGD was performed to remove the food bolus. The biopsies were taken, And this patient was diagnosed with a condition called EOE, or Eosinophilic Oesophagitis. So that kind of brought my interest into this topic. And there's a good paper published by, they were medical students at the time in the University of Dundee, with a general surgical registrar at the time in Nine Loss Hospital, Michael Wilson, and now he's working, I think, in Forth Valley Hospital. And these two students are now, I think, foundation doctors. One is in London, one is in Glasgow. And they looked at the data from 2008 to 2014 of all patients admitted with a food bolus obstruction to Nine Loss Hospital. And they looked under which specialties they were admitted, like ENT, general medicine, or upper GI surgery, and what management was done. And there was quite big variability on how these patients were managed, what investigations were requested, and how many patients were diagnosed with this condition, eosinophilic esophagitis. So whenever you have a time, have a look at this paper. It's really informative. But the data was from 2008 to 2014. My data is a bit more later, 2016, 2019. And in 2016, one of the guidelines came out, which gave instructions about how these patients with food bolus obstruction should be managed and what tests should be done. But of my audit, the objective was to have a look at demographics of these patients admitted with a food bolus obstruction, and patients specifically admitted to ENT ward, and what intervention we performed or was performed to resolve the food bolus obstruction, and what investigations were done to diagnose or exclude the EOE, which is eosinophilic esophagitis. And why EOE? Because in literature, it's been reported it's the single most common cause of food bolus obstruction, and that can be diagnosed early, and it can only be diagnosed with the biopsies. So it was a retrospective study over a 4-year period of patients admitted to ENT inpatient ward. I used clinical portal, ICE, and physical notes to gather the data. And for some of you, you might question, why do patients come with food bolus obstruction to ENT? Why do they go to GI, etc.? So in Nine Loss Hospital, in A&E, the protocol currently is that if the patients feel that the food bolus is stuck in the region of sternal notch or above it, they come to ENT. If it's below, they go to medicine. Limitations of this study, there were times until August 2018 that NHS 5 patients, the ENT NHS 5 patients for acute admissions were coming to our hospital because they didn't have an out-of-hours service for these patients on the weekends. And still in Northern 5 patients who live there, they still come to Nine Loss Hospital during acute admissions, but their follow-up sometimes is NHS 5. Therefore, there might be some data missing because I didn't have access to NHS 5 clinical portal to see the follow-up investigations. So there is a teamwork of all of us, including patient, that are needed and who can diagnose EOE. I'm not going to talk about GP and A&E side today. I'm not going to talk about the patient. I'm going to talk about admitting specialty, and today it's the admitting specialty is the ENT. So demographics of these patients. So there was more males admitted with this with a food bolus obstruction, and males were younger than females, and quite significant difference in the age. Males were the median age was mid-50s, and female age was near 70s. The type of food bolus. The majority of patients, it was the animal-based food bolus, and it's just a small fraction, it was plant-based food bolus. And if you're curious to see what sort of type of animal-based food bolus was stuck in the esophagus, the majority of the meat was chicken, steak, beef, and then going down with including fish eggs as well, or salmon. With plant-based foods, out of curiosity, it was just kind of evenly spread with apples, chickpeas, maybe hitting in two patients. Days of admissions, when they came and were admitted to the ward, there's a variability as well, and you might question why. I don't know as well necessarily, but I think it's due to our behavior as humans, what sort of foods we eat on specific days potentially, and this is just an example. I think it's from Wetherspoons. On different days, they have different type of foods that they serve, and there's like kind of not sales, but yeah, special discounts and special deals. Months of admission as well. There's variability that we had more in winter months and in summer months, and again Why? Maybe as again, it's with our behavior, it's linked to our behavior, what sort of foods we eat. In winter, around December, January, we eat more like turkey, etc. during festive period. And during summer, we consume more barbecue type of food, including meats. And going back to what intervention was required to resolve the food bolus obstruction of the patients presented to ENT, it was half and half. And half of the patients we needed to intervene, and half the food bolus resolved spontaneously with intravenous fluids, maybe analgesia, some muscle relaxants. So in those patients, when the intervention was performed, actually, in the majority of cases, it was the OGD that was done. So we referred these patients for endoscopy performed by GIT. And in a quarter of patients, it was rigid esophagoscopy. And it's important to talk about complications as well. So in each of the group, in rigid esophagoscopy and OGD group, there were one patient in each group that had esophageal tear or mediastinitis. And in percentage, it looks like there's a higher percentage of complications in the rigid esophagoscopy group, but this is not statistically significant because in each group there was only one patient with such complication. And some of you might never seen rigid esophagoscopy. It's a procedure we do under general anesthetic, and we use rigid tools. We can reach kind of mid part of the esophagus fairly safely, but we cannot reach safely the lower part of the esophagus, especially in taller patients. Flexible nasal endoscopy that some of you might heard what we do. This is just a tool that we do it in the treatment room or at the bedside. Sometimes no spray. It's done within 10-15 seconds. And we're able to see voice box, as you can see here. I hope you can see my pointer, maybe not. And yeah, we can enter esophagus, but we cannot visualize it well. So this is just a diagnostic tool. It's not a therapeutic tool that we do. So this is a slide showing the biopsies, whether biopsies were taken during ENT procedure or OGD. As you can see in ENT procedure, in majority of cases, biopsies were not taken. In OGD intervention, in more than half of patients, the biopsies were taken. And when the OGD was done and the biopsy is taken, what was the diagnosis? So here you can see EUE was the diagnosis that was diagnosed the most out of all these patients. And then during rigid esophagoscopy, when the single biopsy was taken, it was inconclusive. So what about the follow-up? If these patients don't get biopsies taken during OGD, or their food bolus resolved conservatively, what was the follow-up? As you can see here in the red, that the majority of patients, the follow-up was not organized, but there was no follow-up, not that it wasn't organized, there was no follow-up. In the yellow colors, it's a suboptimal type of follow-up because these type of investigations or clinic visits do not diagnose the EUE or exclude the EUE. Then when the ENT intervention was done to resolve the food bolus obstruction, again, in majority of patients, the follow-up was not arranged. And same with the colors for the barium swallow, it does not, we're unable to exclude EUE with such an investigation. And when the OGD was done, but the biopsies were not taken, again, in majority of patients, the follow-up was not, there was no follow-up. And summary of previous slides, just to give you the whole picture, in majority of patients, we did not arrange any follow-up. And about the inpatient stay for these patients might be interesting for managers, thinking of how many days these patients take the beds. Majority of cases is 1 to 2 days. It's basically until they get the intervention performed and they're able to go home. Some of these patients that stayed longer, it's because of the complication, the mediastinitis or esophageal tear, or they were palliatively looked after. And then when the OGD was organized, and the follow-up was organized specifically with the outpatient OGD or transnasal oesophagoskopy or TNO, here you can see on the left-hand side in the OGD group, nearly in all patients, the biopsies were taken. In one patient, I think the patient did not tolerate the biopsy, so a follow-up OGD, another one was arranged. And in TNO group, the biopsies were not taken. And what was the diagnosis of this outpatient OGD? Again, the majority of patients, it was the EUE. If for most of us, or some of us, the EOE is not kind of like a severe diagnosis, but the reason why we should follow these patients up is here is only one patient. I know it's only one, but one is enough. One patient with adenocarcinoma. So if this patient wouldn't have had a follow-up, the diagnosis would potentially be late. I don't know what was the treatment for this patient, whether it was curative or palliative, but yeah, it's still important to do the OGD for these patients. And summary of inpatient and outpatient OGD biopsy diagnosis, here it is. It's the eosinophilic oesophagitis is the most commonly diagnosed condition. And the guidelines as well inform that there's a specific number of biopsies that should be taken during OGD and specific levels, meaning the number of levels, at least in 2 or more levels, and at least 6 or more biopsies should be taken. And I looked at those patients when the biopsies were taken, that in less than a third of patients, the biopsies were taken appropriately, meaning the appropriate number and levels of biopsies. And in the rest of the patients, it wasn't taken appropriately. So the good number of biopsies received in pathology, this was, I spoke to the pathology department, they like when on the request form, it's written actually that there is how many biopsies were taken, so they can physically find these biopsy tissues. So a good example is a specific number of biopsies that were taken. Not so good when it's 1 plus multiple, because it's not a good practice. And the reason why there should be a specific number, or like number of biopsies should be taken from specific levels, number of levels. This is a good example of one patient that I remember. The patient was admitted in 2016 with chicken foot bolus. I think this was a different patient from the initial patient that I put in the first slides. OGD was done as an inpatient, 2 biopsies taken, and the diagnosis was reflux esophagitis. Then the follow-up OGD in 6 weeks' time did not take place for a known reason. And then after 2 years, patient had outpatient OGD. I think the patient was referred by the GP, and it showed trachealization of esophagus. What trachealization of esophagus means? It's basically esophagus looks like trachea from when the scope is done, and it just shows the type of stenosis of esophagus, which affects the quality of life as a swallow process. And at that time, the 6 biopsies were taken from 3 different levels, and the diagnosis was made of EOE. And going specifically into pathology report, and this I've spoken as well to pathology department, they're fully aware of it. So the diagnostic criteria for EOE in biopsies is that there should be a mention of eosinophil count in high power field, and it should be 15 or above. And in half of the patients, it was specifically mentioned. In half patients in the pathology reports, the number of eosinophils was not mentioned. Here's an example. So a good example, a specific number or acceptable in some ways is, it's above 15, above 30 eosinophils per high power field. Not so good example was described in words like mild infiltration, predominant infiltration of eosinophils, etc. It's not a good practice. Good practice is a specific number of eosinophils mentioned. So of those patients in our cohort that were diagnosed with EOE, so their mean age was, they're young patients, mean age was 28 years of age. There's more men were affected with this condition, and food bolus type in 100% of cases, it was animal-based food. The animal-based food does not mean the causation that it's causing the EOE, but there's association. And about eosinophilic esophagitis, just briefly, there are 2 big stages here on the bottom. You can see acute allergic inflammation, and then you can see chronic inflammation. If the diagnosis is made during the acute allergic inflammation, it's reversible condition in some ways that it can be maintained. The patients can be asymptomatic with the treatment, and it does not progress, at least as quickly as if it's not treated. In a chronic inflammation, there's trachealization of the esophagus, there's stenosis. That's going to affect their quality of life significantly, and the treatment options are fairly limited, and they're more severe with some complications as well of the during the procedures to dilate these strictures. And here you can see different type of pictures of esophagus. And some you might see furrows. For example, I don't know if you see my pointer, but on the right middle picture, you can see some furrows there. And on the right top, you can see some trachealization. That's esophagus. It looks like trachea, but that's esophagus. And that's the description of trachealization. Here you can see on the top left, you see some white spots. You might think, oh, maybe that's just fungal infection, potentially, maybe nothing. But actually, that's as well diagnosis of eosinophilic oesophagitis when the biopsies were taken. So it's important to take biopsies because despite normal-looking esophagus, in patients presenting with fluid bolus obstruction, that we need to exclude, or patients need to, the clinicians need to exclude this condition. So the results of this study: males were admitted twice more than women. Animal-based food was presenting food bolus in 91% of patients. Intervention was required in half of the patients to resolve the food bolus obstruction. Higher complications was with the rigid oesophagostomy. But again, in our case, it wasn't statistically significant because there was only one case in each group. And nearly half of the patients, when the biopsies were taken during OGD, the tissue diagnosis was eosinophilic esophagitis. And in our patients, follow-up was not arranged in more than half of the patients, in those patients that didn't have the tissue diagnosis from the admission. And if we look specifically at the biopsies, they were not taken appropriately in 71% of cases. And in patients who have diagnosed EOE, the specific number of eosinophils above 15 per high power field were not specified in half the patients. In conclusions of our audit, EOE is the most common cause of food bolus obstruction that can only be excluded with the biopsies during OGD or transnasal oesophagoscopy. OGD is a better choice of the intervention for removal of food bolus, specifically if we're thinking of eosinophilic oesophagitis. And during the food bolus removal with OGD, biopsy should be taken and not postponed for outpatient OGD, ideally. And when biopsies have been taken, a specific number of biopsies should be mentioned, from which level of esophagus they were taken. And specifically, clinicians should query eosinophilic esophagitis on request, because then it triggers the thinking pathway for the pathologist. They need to count the eosinophils, they need to consider this diagnosis. And our findings show that EOE is underdiagnosed due to suboptimal investigations and follow-up. And we know, and literature states this, that delayed diagnosis of EOE leads to morbidity. And something that I didn't look at in my audit, but it's important as well when we think of food getting stuck in esophagus, we have to as well assess the patient's teeth, their dentition, and whether they have to wear dentures or there's some misalignment of the dentures. They need to see a dentist. So that's something as well we have to think. And there is a teamwork, as I stated before. Especially these patients are admitted under the intervention that we do, the biopsies that should be taken during OGD, and the pathology report, which should state specific things to exclude the diagnosed EOE. Because ultimately, we look after the patient. Patients have to live with this condition. It's a chronic condition. And the later it's diagnosed, later the treatment is started, later they're informed about their condition, they run into more severe morbidity. And just some facts about Tayside. Literature states around the numbers differ between the publications, but there is 13 in 100,000 people annual incidence of food bolus obstruction. And in Tayside, if we look at the numbers, are just about 400,000 people. So annually, there will be just about like 50 people having food bolus obstruction. And if we cover some part of NHS 5 as well, there'll be more patients. And what's happening now? This is just again, fun fact maybe, but the consumption of at least poultry meat has increased in the UK over the years. So more patients eating type of foods that more likely to stuck in esophagus, we might see more of these patients presenting to A&E, to GIT, to ENT, to GPs. And what do societies say? So there's SG and there's ASG, if I pronounce it correctly. But basically they say that that method of intervention to retrieve food bolus is flexible endoscopy, primarily OGD, but transnasal esophagoscopy as well can be used. And at times, when food bolus is very high and OGD, during the OGD, there's a difficulty to visualize the esophagus, then yes, the rigid esophagoscopy can be helpful and can be useful. And about this, what we have in 9 wells and some hospitals as well across UK is the point where patients feel where the food bolus is stuck, and the mark being suprasternal notch. If it's above there, then above it, then it's ENT. If it's below it, then it's GI team or medicine or upper GI surgeons. But actual research has shown that this, where patients point, does not correlate with the site of obstruction. So it's something that we've been using for some time as a reference, but actually doesn't have any evidence base. It's not based on anything. And then biopsies during OGD. Ideally, the biopsy should be taken during the OGD, which is done to remove the food bolus obstruction, and then once it's done, to perform the biopsies. I understand, and I've spoken to GI colleagues, they say that sometimes patients don't tolerate well the removal of food bolus obstruction, removal of food bolus, and then to do biopsies, it might be too big of an ask. Then they arrange a follow-up appointment for OGD, but sometimes these patients do not come for follow-up. It'd be good actually to see maybe if our colleagues in IMOS could do an audit to see if they don't do biopsies, and then they arrange a follow-up, how many of these patients come and how many don't come. Because one of the aims of this presentation was to show that rigid esophagoscopy, what we do it under general anesthetic. So if there's a fear the patient might not tolerate OGD for food bolus removal under sedation, then maybe these patients should get general anesthetic for removal of food bolus obstruction. And I've performed, I think, a couple of removal of food bolus obstructions with my GI colleagues in the theatre under general anesthetic, because the cases were difficult. And the most up-to-date British guidelines, they were published in May 2022, and this is something for maybe GI team or medical colleagues to have a look at it. And they go into details about recommendations, level of evidence, about use of OGD, about biopsies, about how these patients should be managed to diagnose or exclude UE. And I listened to this talk, it was like on 18th of November, I think, by Professor Sir Gregor Smith, and the Chief Medical Officer for Scotland. And I like what he pointed these out as well, what Dr. Catherine Calderwood prior to him talked in Realistic Medicine talk. It's about changing our style to share decision makings. Sometimes actually, I don't know, maybe it's just a bit controversial, but if we would ask a patient, what would they prefer? Rigid esophagoscopy under general anesthetic and then a follow-up OGD, or would they just want to have an OGD and get the biopsies done at the same time? I don't think we ask patients for their choice, what would they choose? But again, that's what maybe for some it might sound controversial. But then with such planning, we could potentially reduce waste as well. Waste meaning one procedure is done on the general anesthetic, then a follow-up procedure is done for diagnosis. Maybe we could combine this and just it saves some money, save time for the patients, save resources. And I like this unwarranted variation because I've spoken to my colleagues in Scotland. The practice is very similar, like we have it here in Dundee with these patients. But in Wales, where I was a few months ago, in some hospitals, no, these patients don't come to ENT. But again, I'm not here to say should they come or should they not. I'm here to just to share some of these points. These are some of the references, and that's the end of my talk. So happy to take any questions if you have any. I'm happy for the discussion.
Thanks very much, Rasad. My lunch was salad, and I have not suffered a food bolus during your presentation.
Very
So
good.
thanks very much. That's all very interesting stuff. There's plenty of ENT folk around the virtual table who may have something to say, and I'm just trying to see if there's any gastroenterologists. But I was interested in the sternal notch thing, but certainly in cough, which is a symptom that we share across ENT and respiratory medicine. People often spend a lot of time trying to isolate where they feel the cough is coming from. I can feel it here, I can feel it here, and it makes absolutely no difference. It doesn't predict anything at all. So it's interesting to hear you say the same thing for this. We see a lot of, not a lot, we do see dysphagia in acute medicine, and we spend time saying, whereabouts do you feel it gets stuck? And perhaps you think that that's a waste of time.
I think it's a waste of time to decide to which specialty these patients should go. Maybe that might help the endoscopist or GI doctor to decide where they should pay more attention to, what to anticipate, expect. We in ENT, what we use, we don't actually use where they feel it's stuck. We give them a sip of water and we count seconds, how long it takes for them to bring it up. If it's like within a few seconds, we feel it's very high. If it's after 20 seconds, it's fairly low, we'll not reach it with a rigid esophagoscope. So we use that as a kind of point of reference where it
That's a very practical approach to the problem. I quite like that. Now, you present data for people who have a food bolus obstruction who get to hospital. Is there a big chunk of people who get a food bolus and then just sit it out at home, it sorts itself out and never present? Do you think that they're going to have undiagnosed EOE as well, and that's a group to try and find?
Potentially, yes. What we've done is with one of my colleagues, some of you might know Fahid Ahmed. He was a foundation year doctor here in Nine Wells. He's now in Glasgow. He worked in A&E, and he noticed as well in A&E, a fizzy drink is given to these patients who present with a food bolus obstruction. Food bolus resolves, they're sent home. What happens to these patients? So he's looked at that, and he's presented in Belfast recently as a poster. So we're gonna try to publish that as well, or present some, or maybe even for this meeting as well. I'll let him know. But yes, there will be quite many patients that we don't know about. And some might ask, should we do anything about these patients? Yes, I guess if someone would look into when a patient is diagnosed with the EOE, how many years before or how many months before they start to have these issues with the food bolus obstruction at home. So, and if they, at the time when they've been diagnosed with EOE, they have trachealization, maybe then these patients should have been, seeing their GP, and GP should be a bit more aware of this condition. For some GI colleagues, it might be, there might be an overflow of these patients for endoscopy. Yes, again, there might be something to look into whether the department could cope with it. I know in Edinburgh what they do in their department in Leith, they use transnasal esophagoscopy GI team. It's a quicker procedure, no sedation, just local anesthetic, and it speeds up the process.
Does anybody in the audience have any questions for Rasad or comments about this? Like I said earlier on, all of us who've done an A&E job have seen food boluses.
I see a question about the treatment.
Oh, here we go. Steph has said, what is the treatment for EOE, and is there any value in treating food bolus patients without diagnostic biopsies prophylactically?
So I will disclose, I don't treat patients with EOE, so don't take this as a guideline. The treatment, what is the treatment? There are two ways of treating, or maybe three we can go into. One way is prophylactic meaning like a dietary change. Some would say, oh, it's very difficult to implement for patients, maybe for average Scottish person to avoid some type of foods. And there's six food diet elimination therapy, and I divide it in two groups. One is animal based, one is plant based. So plant based is soya, wheat, and nuts. Because there's underlying allergy, some sort of allergy, but you cannot diagnose it with a skin prick test or blood test. So those three, so soya, wheat, and nuts. And animal based was dairy, eggs, and I think seafoods, sort of like shrimps. So most of the time, if I remember correctly, what first, if a patient can try to eliminate two types of foods, it would be dairy and wheat. I think that was suggested. And I think Mike Miller, who's a hepatologist who runs EOE clinic in Niles Hospital, I think he gave us a talk in ENT department. Don't misquote me, but I think, or I might misquote him, but I think people who are, it'll be good to have a look at the type of patients who are vegans. I know people who just holding their heads or another vegan, pro-vegan person. But if someone would be plant-based vegan group and one will be, meat eaters, for example, it will be interesting to look in a longitudinal study to see are vegans affected as well with it, because soy, nuts as well play a role in this condition. So one is to diet, then steroids is the treatment, because this is a chronic condition. You will not be able to reverse this condition very likely because it's a chronic condition. So steroids used to be, they used, so this is for respiratory clinicians, quite interesting results here. Inhalers, steroid inhalers, the patients were instructed to swallow rather than to inhale, to swallow. But now there's oral dispersible budesonide. The brand name is Jorveza, and I think they take it at night, and they, after they've brushed their teeth, that's the last thing, they just drink and it coats the esophagus and they don't eat anything after that. So that's a treatment. And the third would be, if there's strictures, it's a procedure with dilation, etc. And then maybe for respiratory colleagues, a biologic, which is not going to be used for this condition yet, dupilumab, is shown that it as well helps for this condition in patients who have severe asthma, etc. It helps as well for EOE, but it's not licensed in the UK for its use yet. And something prophylactically, is there any value in treating? I don't know. I think OGD is warranted because you don't know it's EOE until you exclude it. And if you don't do OGD, they might have something else called. Ultimately, the bottom line is food should not get stuck in esophagus. That's the bottom line. If food gets stuck in esophagus, something is wrong. And conditions, if we don't worry about EOE, cancer needs to be excluded, and then EOE is the next condition that should be excluded.
So that's something it's interesting, isn't it? What the hit rate is if we were to, clearly you're targeting a population where if it's stuck and you need a surgical removal, then there's a very, very high risk of something wrong. I think that's very clear. But if it was a transient obstruction that fixes itself, or the can of Coke gets rid of it, and where do they go? And they don't get follow-up. But is that enough of an obstruction to warrant stuff? And I suppose your colleague's poster and subsequent publication may help us with that. I'm reticent to add work to my GI colleagues because they do an awful lot of scopes as it is, but it may well be that that's another thing that we should be doing more of because it does have a pickup rate. Any more questions from the floor? I think we may have come to a natural conclusion. I think so. So thanks very much, Rashad, for your talk. Very interesting.
My pleasure.
Inside the chest, but outside the chest. So that's excellent. Next week, Grand Rounds is John Ellis, ophthalmologist, who's going to come and talk to us about his experiences and his role in the transformative change for cataract surgery here in NHS Tayside. It's been in the press quite recently, the massive increase of throughput through the cataract service whilst maintaining high standards of good quality. And he's going to come and talk to, his talk is called The Magic Sauce. So we'll see what that's all about. John's a very good speaker and has a lot of experience in this area. So well worth tuning in for him next week. Grand Rounds is available on YouTube. If you just search Dundee Grand Rounds, you'll find it. It's the first thing to pop down. And you can see Grand Round videos back to 2015. There's a little bit of a hiatus whilst I upload and edit them, but they are coming and I'll work on it over Christmas if there's any missing. If you'd like to speak at Grand Rounds, then please do get in touch. We've got about 5 slots that are empty for the spring semester. Anything at all that you find interesting, you think we would find interesting, if you know a speaker you think would be interesting to the general audience, please get in touch. We're very keen to hear from a wide range of specialties, our nursing colleagues, professionals allied to medicine, anything and everybody here at Grand Rounds. So thanks very much. Enjoy the rest of your day. Have a good weekend, and I'll see you again next week. Thanks again.